Okay, let's unpack this. When you think about the healthcare conversation, where does your mind usually go?
We immediately think of the big things,
Right?
the doctors, the surgeons, the technology.
Exactly. We focus almost universally on what I'd call clinical excellence. You know, the groundbreaking research, the sterile efficiency of a surgical theater, the really complex pharmacology, or maybe the labyrinthine structures of insurance.
Right. We spend billions, literally billions, optimizing the care that happens inside the hospital wall.
We do. And in doing so, we operate on this quiet and really dangerous assumption
Which is,
that the patient will just materialize at the scheduled time, mentally and physically prepared, and just be ready to receive that optimized care.
we treat the logistics of getting there as an afterthought, like a personal errand the patient has to run, not part of the care itself.
And that assumption that logistics is a side issue, that it's just a simple matter of personal travel, that is exactly where modern healthcare systems harbor one of their most foundational, most overlooked vulnerabilities.
Yeah.
So today, we are diving deep into this quiet reality that transportation is not merely a convenience, it is a non-negotiable prerequisite for care. It functions, quite literally, as a gatekeeper.
The gatekeeper.
Yes, and when that gate is stuck, the most advanced, the highest quality care in the world remains fundamentally, completely inaccessible.
The term gatekeeper is pretty loaded. It suggests that this seemingly simple physical hurdle, maybe just a mile or two across town, is actually blocking access to a highly complex multi-trillion-dollar system.
It is.
I think for a lot of people listening, the initial reaction might be skepticism. I mean, is transportation really that influential?
It feels like it shouldn't be, right?
Right. We're talking about incredibly sophisticated medical outcomes, things like managing heart failure, defeating cancer.
Yeah.
And you're saying that could be dictated by whether or not someone can secure a reliable 15-minute ride.
Yeah.
Why is this? This basic logistical need so often dismissed or ignored when we're discussing massive public health strategies.
I think it's dismissed precisely because of its apparent simplicity.
It's mundane.
It is. It's too mundane to fit into the narrative of high-tech, heroic medicine, but its impact is catastrophic. Think about the fundamental equation of healthcare delivery for a second.
Okay.
If a patient cannot physically arrive at the location where care is scheduled reliably and on time, then what good is anything else? The skill of their doctor, the efficacy of their medication, the comprehensiveness of their insurance coverage,
It all becomes null and void.
it all becomes null and void. The advanced system fails at step zero, right at the point of access. We have to internalize this truth. Transportation reliability doesn't just enable care. It determines whether care happens at all.
So what you're really asserting here is that the primary failure in many cases isn't clinical, it's logistical.
Often, yes.
And the argument here is that ignoring this logistical necessity is just no longer tenable in a system that's increasingly focused on continuity of care and on value.
Exactly. And while this problem exists across the board, its acute failure is really concentrated among specific vulnerable patient groups.
Okay, so this isn't about the person who can just call an Uber on a whim or, hop in their own car.
Not at all. This becomes critical for individuals whose health literally depends on frequent, routine appointments. Consider a patient who needs dialysis 3 times a week, every week. Or think about a cancer patient who's undergoing daily radiation treatments for 6 weeks straight.
Your entire health outcome is absolutely shackled to their ability to complete that intense, repetitive schedule.
Completely. A single failure in transport can disrupt the entire protocol.
And I imagine the issue just compounds exponentially for people with mobility limitations.
Oh, absolutely.
I mean, public transit, even if it's available, often requires navigating stairs, long walks to the bus stops, dealing with tight scheduling,
Yeah.
which is just infeasible if you rely on a wheelchair or have severe joint pain.
That's right. For many, mobility limitations aren't just an inconvenience. They are a hard stop sign for standard public transport. It's just not an option. These patients require specialized and often very expensive accessible transport solutions.
And then there's a third group.
Yes. Add to this a critical third group, those operating on fixed or low incomes. The cost of a last-minute taxi or even just repeated bus fares can create genuine financial strain.
So they're forced into an impossible choice.
An impossible choice. When you're faced with deciding between paying for your critical medications, for food, for rent, or paying for the transportation to get to the clinic, the appointment often loses. That decision forces them to skip essential care.
So if that transportation gate fails for these specific groups, the chronically ill, the mobility impaired, and the financially vulnerable, the subsequent failure isn't just a missed time slot on a doctor's chart.
No.
It's a complete breakdown of the complex cumulative effect of a treatment pathway that was designed assuming perfect adherence.
The harsh reality is this. Without dependable, accessible transportation, even our most sophisticated healthcare systems cannot deliver consistent population-level outcomes. And the reason is simple. Large swaths of the population simply cannot consistently arrive. That, right there, defines the scope of the problem.
Okay, that defines the problem very clearly. But now, let's move past the definition and get into the measurable fallout. What is the immediate and maybe the less obvious cost of this gatekeeper failure?
That brings us directly to this concept of cascading effects. Because a no-show, a missed appointment, it doesn't just vanish into the ether. It sends these ripples of strain throughout the entire healthcare ecosystem.
Ripples that affect everyone.
They impact providers, they disrupt the patient's own health trajectory, and they increase the overall financial burden on the system.
Okay, walk me through the system strain first. When a patient is scheduled and they don't arrive, the obvious loss is, well, valuable provider time.
Right.
You have a highly paid specialist, a surgeon, or a primary care physician who has dedicated that 15, 30, or maybe 60 minutes to that patient slot. That time is now lost. But where does the real financial burden lie? I mean, if the clinic didn't render the service, they didn't incur the direct cost of the service itself.
That's a critical question. And it pushes us beyond just the simple loss of billable revenue. Because while the service wasn't rendered, the entire operational structure around that service was already mobilized.
Ah, so all the fixed costs are still there.
Exactly. The facility was heated and lit, the reception staff checked the room, the nurse prepped the chart, and the physician sat there waiting. All of those fixed and marginal costs are still incurred. But furthermore, and this is crucial, the clinic experiences scheduling inefficiencies that don't just affect that one moment, they ripple through the entire day.
So the carefully calibrated rhythm of the clinic day is shattered.
Shattered is a good word for it. When you multiply those lost 15-minute slots across several patients a day, every single day the clinic's workflow is severely disrupted.
And that disruption probably forces them to adopt some kind of coping mechanism.
It does. It often forces clinics to adopt a strategy of overbooking just to compensate for the anticipated no-shows.
And what's the consequence of overbooking?
Well, you know what it is. It leads to severe frustration, prolonged wait times, and ultimately a much poorer experience for the patients who did manage to arrive on time.
So the people who show up are penalized because of the people who don't.
That's right. The overall system efficiency takes a huge, measurable hit, and that increases staff burnout and widespread patient dissatisfaction. It's a vicious cycle.
Okay, that paints a really clear picture of the provider's operational headache. Now let's flip it and look at the patient side of this cascading effect. If a chronically ill person misses one appointment, they just reschedule, right? It seems manageable on the surface.
If it were always manageable, the consequences wouldn't be so dramatic. But for patients with chronic conditions like congestive heart failure, or for those recovering from a major surgery, missed appointments mean delayed monitoring.
And that monitoring is critical.
Absolutely. Crucial tests, maybe a blood panel to check potassium levels or an adjustment to an anticoagulant dose, those things are postponed. This interruption to the treatment plan can quickly turn a stable situation into a very volatile one.
And if those interruptions become frequent, I assume the patient's condition just spirals toward a critical point.
Precisely. The really dangerous consequence is that when routine, preventive, or maintenance care breaks down due to lack of access, the patient's condition is left unmanaged or poorly managed until it deteriorates into a full-blown crisis.
Can you give me an example?
Sure. Imagine an elderly diabetic patient who misses 2 crucial foot exams and insulin adjustments over a 6-week period because their transportation keeps failing them.
Okay.
Suddenly, they develop a severe infection. That infection requires emergency hospitalization and potentially life-altering surgery.
So the logistical failure pushes the patient from the affordable preventive setting, which is the clinic, into the most expensive, least efficient setting, the emergency room.
Absolutely. Their increased reliance on urgent or emergency services isn't just bad for the patient, it is the most costly way for the system to manage a chronic illness.
Okay, that brings us back to accountability, and I have to press on this. It's the classic counterargument that I'm sure many listeners are thinking about right now.
I know which one.
Isn't a missed ride fundamentally a matter of individual responsibility? Why should the healthcare system internalize the massive cost of what appears to be someone's failure to figure out their own logistics? We need to really emphasize the systemic nature of this issue.
That is the pivotal distinction, and we have to move this discussion beyond personal accountability and towards systemic barriers. Of course, individual choices play a role,
No doubt.
but when we observe high rates of no-shows that are consistently clustered among highly specific demographic groups, people living in transit deserts, low-income communities, or older adults requiring complex medical setups, it stops being a random collection of individual failures.
It becomes a pattern.
It becomes a reflection of a systemic barrier. The health system, in its singular focus on clinical optimization, failed to optimize the environment of access.
So, in essence, the system successfully provided the service, but it failed to build the bridge between where the patient lives and where the clinic is located. That logistics gap itself is a health determinant.
That's a great way to put it.
Now, tell me, beyond the immediate loss of provider time, how do these repeated failures translate into quantifiable hard costs and massive financial burdens for the system as a whole?
Okay, let's analyze the total system cost, which is far greater than the lost revenue from a single visit. We talk about provider time, but let's talk about administrative waste.
Right.
Repeated no-shows dramatically increase the administrative burden. Just think about the staff, the nurses, the schedulers, the support personnel who are spending countless hours on inefficient, non-revenue generating tasks.
So staff time just chasing down patients, trying to reschedule, sending repeated reminders, updating electronic health records,
Yeah.
dealing with potential documentation errors,
Yeah.
because the planned service was never actually rendered.
Exactly. The clinic is paying skilled labor to manage failure instead of focusing on health outcomes. This constant churn, the sheer inefficiency and administrative overhead associated with trying to recover from missed appointments, it drives up the overall operational costs for every single clinic and every major health system.
And these are hidden costs, right? They're often just absorbed into general overhead,
Yep.
but they must be substantial.
They are substantial. If a system has, say, a 15% no-show rate, you can bet that 15% of its administrative capacity is likely tied up just managing the fallout of those missing patients.
So unreliable transportation acts as a constant low-level operational drag. It's just consuming resources that could otherwise be dedicated to patient care or expanding services.
Precisely. And when you look at modern healthcare models, particularly those moving toward value-based care, unreliable transportation is an operational anchor. It guarantees financial disruption and higher expense.
It makes those models impossible to execute effectively.
It does. The core insight here must be recognized by administrators. Investing in transportation reliability isn't a charitable expense. It is a necessary, proactive financial maneuver for reducing substantial, avoidable administrative disruptions and clinical failures, which ultimately reduce the system's ability to generate value.
It sounds like an actuary's dream, really. You calculate the cost of a missed appointment, the cost of an avoidable readmission, and then you realize the relatively small investment in reliable access pays for itself many times over in efficiency and prevented crises.
It's an operational necessity. We need to start framing it in terms of performance metrics. If a system can move its appointment completion rate from, say, 80% to 95%, the efficiency gains are massive.
How so?
Well, from the utilization of examination rooms to the optimized workflow of the highest paid specialists, transportation is the lever that stabilizes patient flow, and by extension, the entire system's financial and operational health.
That transition from the micro cost of one appointment to a systemic necessity is really clear now. So let's zoom out even further and place this problem into its proper public health context. We've established the immediate operational cost, but what about the impact on the broader community? How does transportation fit into the macro view of public health and inequality?
This transitions the discussion perfectly to the macro level, and it introduces the framework of social determinants of health, or SDOH.
SDOH.
Yes, this is where we stop treating the problem as a mere logistical footnote, and we start seeing it as a fundamental root cause of health inequality. The goal is to move the conversation from, does the patient have a car, to, is the environment setting this patient up for success or for failure?
I know SDOH is a term that's widely discussed now, but it's often in very abstract terms, so let's ground it for a moment. Clearly define SDOH and explain why transportation deserves such a central place among those other determinants like housing and economic stability.
So we define SDOH as the non-medical factors, the conditions in which people are born, grow, work, live, and age that profoundly influence their health outcomes.
So we're talking about things like neighborhood stability, access to education, economic security.
Exactly. And transportation must be positioned squarely within this category. It's often referred to as being part of the neighborhood and physical environment. It is the physical link between a patient's socioeconomic circumstances and their ability to leverage available medical resources.
So the simple existence, or more often the glaring absence of a dependable, affordable ride, is being deemed as structurally critical to long-term health, as having a roof over your head or access to nutritious food.
Yes.
That elevates the status of this issue dramatically.
It absolutely does, because access affects whether individuals can attend the full spectrum of necessary care, not just acute care when they're already sick.
So not just the emergency visit.
No, we're talking about the routine checkups that catch hypertension before it causes a stroke. We're talking about those crucial follow-up visits after a hospital discharge, which are essential for preventing a costly readmission. It's about attending rigorous physical therapy and rehabilitation sessions, and, crucially, accessing preventive screenings, mammograms, colonoscopies, immunizations that save lives in the long run.
And if that transportation barrier is consistently present, the individual isn't just inconvenienced. They are systematically shut out of the entire proactive and preventative side of the healthcare equation.
That's right.
The system is theoretically available to them, but it's practically inaccessible.
Absolutely. And this is where the logistics failure translates directly into health disparities. The patient might have Medicaid, they might have excellent private insurance, but if the bus doesn't run reliably or if the cost of the ride is prohibitive, that insurance card is useless.
That brings me directly to the equity challenge.
Yeah.
We can use abstract terms like poor outcomes, but I want specific clarity on how the lack of a ride fundamentally affects the continuity of treatment, that crucial thread that holds long-term health management together, especially for complex diseases.
Okay, let's ground this in a real-world scenario. Let's take a patient managing type 1 diabetes.
A very complex
It's
condition.
very complex. It requires daily monitoring, strict medication schedules, and regular visits to an endocrinologist for A1C checks and dosing adjustments. Continuity for this patient means attending those quarterly appointments and having consistent access to specialists.
And if transportation is unreliable,
Those appointments are missed. The patient might start making dangerous unilateral adjustments to their regimen based on old advice. Or worse, their condition might just slowly and silently worsen without that expert oversight.
and for treatments that are temporally rigid, things like chemotherapy or radiation,
Well, the impact there is even more immediate and severe. Cancer treatment protocols are designed with rigorous, timing-specific dosages delivered on specific consecutive days.
the schedule is the treatment.
The schedule is the treatment. Missing even a few of those sessions can compromise the entire therapeutic course, reducing the treatment's efficacy and potentially leading to a much worse prognosis. A patient can be cured on paper, but if they miss the ride that delivers the final critical cycle of treatment, the whole pathway fails. This logistical failure essentially sabotages the clinical excellence.
So the system has effectively designed these incredibly sophisticated clinical protocols that assume perfect logistical performance. And when that assumption fails, the most vulnerable patients suffer the most profound consequences.
And the data shows exactly where these effects are most pronounced. It is the communities with limited or non-existent reliable transportation options that experience the highest rates of missed care, delayed diagnosis, and subsequently poorer continuity of treatment. We're talking about three distinct groups that really bear this disproportionate impact.
Let's focus on those groups. I'd imagine the first one, the most intuitive one, is older adults.
Yes, older adults. They often face reduced physical mobility, which necessitates specialized vehicles. They may have lost the ability to drive, and their financial resources may be fixed or extremely limited, making reliance on external transport essential.
And they're also the group that needs the most care.
Exactly. They are often navigating complex polypharmacy and multiple chronic conditions, which requires the most frequent, consistent access to care. A canceled ride for an 85-year-old on a snowy day can have deadly consequences.
Okay, and the second group you mentioned would be those with disabilities, which goes beyond just needing a ramp on a van.
Absolutely. Individuals with disabilities often require specialized, accessible, non-emergency medical transportation, or NEMT. Standard public transit is often just not physically accessible, or the travel time required is too exhausting or unpredictable for their condition.
So the solution needs to be tailored.
It has to be. The transportation solution must meet a very high standard of functional accessibility. That includes having trained drivers who can assist with transfers and specific equipment. A failure here is not just an inconvenience, it's a human rights issue surrounding access to care.
And the third group is defined more by geography, those living in rural or deeply underserved urban areas.
Yes. For those living in rural America, the core issue is distance. Healthcare facilities are often centralized in county seats, making a simple doctor's visit a 60 or even a 90-mile round trip.
And public transportation is often non-existent in those areas.
It often doesn't exist at all, and the population density is too low to support scalable NEMT services. A doctor's visit becomes a full-day logistical operation costing significant time, money, and potentially requiring a friend or family member to take a full day off work to help.
So in those rural transit deserts, the lack of reliable, scalable transport isn't just an inconvenience. It's a constant systemic drain on their health access. It ensures that socioeconomic disparity translates directly into a concrete, measurable health disparity.
Precisely. This is why framing transportation as an SDOH is so powerful. It forces organizations to recognize that if they genuinely want to improve health equity and lift population health metrics, they must first invest in addressing these foundational non-medical systemic factors. You must solve the logistical problem to unlock the clinical solution.
Okay, let's shift our focus now from that structural framework back down to the granular level of the patient's experience. You emphasized earlier that in the healthcare context, reliability has to triumph over speed. That really challenges our modern fixation with faster is always better. Why is reliability over speed the essential value proposition in non-emergency medical transportation?
It's fundamentally about establishing trust and eliminating harmful uncertainty. In retail or food delivery logistics, speed is paramount.
Right, I want my package now.
Of course. But in healthcare, the true value is in predictability and consistency. If a patient knows, without a shadow of a doubt, that their accessible transport will arrive precisely at 8:45 a.m. for their 9:00 a.m. appointment, that certainty allows the clinic to function efficiently. But more importantly, it allows the patient to mentally prepare.
That consistency becomes the structural backbone for the patient's own mental and physical health management.
Absolutely. Now contrast that with unpredictable transportation. If the ride might be 15 minutes early or it might be 30 minutes late, the entire appointment is compromised.
How so?
Well, the patient is anxious while they're waiting, potentially in discomfort or pain. The provider is anxious, wondering if they should fill the slot with another patient or just wait. And most critically, that unpredictability introduces chaos, and it causes us to miss crucial windows for timely intervention or diagnostic procedures.
So a patient might even delay care because of that uncertainty.
They might. A patient might delay a serious but non-acute procedure simply because they fear the transportation system will fail them on that critical day, forcing them to reschedule everything.
I want to really probe the connection between these logistics and the psychological outcomes. Why does reliability contribute so profoundly to patient confidence? We're talking about a vehicle schedule, boosting someone's mental fortitude and their compliance with complex medical instructions. How does trust in the simple act of getting a reliable ride translate into better adherence to care plans?
Patient adherence, the willingness to consistently take medications, follow through on dietary advice, and attend those critical follow-ups is profoundly intertwined with a patient's belief that they can successfully navigate the healthcare ecosystem without undue trauma.
Okay, explain that link.
Think of the mental load involved in managing a serious illness. The patient is already carrying immense weight, worry, fear, physical pain, and the sheer complexities of their medication regimen.
And if every single appointment requires a stressful logistical battle, a confusing booking system, dealing with last-minute cancellations, or just a long, cold wait outside, that patient starts their medical interaction already depleted. They're anxious and perhaps even defeated before they walk in the door.
And that anxiety and logistical fatigue can easily overshadow the clinical advice they receive. When patients trust that transportation will be consistently available and reliable, that external source of stress is just removed.
And with that stress gone.
They are far more likely to schedule their follow-ups, and crucially, they are far more likely to keep them. That consistency in attending appointments directly leads to better adherence because they're receiving timely instruction, necessary feedback, and they're staying on track with their provider's evolving guidance. Reliability doesn't just enable the ride, it removes a massive source of psychological resistance to treatment.
So what you're saying is we need to drastically expand the scope of what constitutes the patient experience. Most quality care metrics stop at the moment the patient walks out the clinic door.
They do.
But you're suggesting that outcomes are significantly influenced by the patient experience before and after the actual clinical interaction. It encompasses the entire journey.
This is a fundamental, necessary shift in how we define quality. Healthcare is a service continuum that starts at the patient's home and it ends when they are safely returned. If the patient arrives stressed, late, or physically uncomfortable due to a rough journey, their engagement during the clinical appointment will suffer.
So they might be less attentive to instructions or...
Or they might rush the doctor because they're already worried about the return trip.
And if they have a negative experience leaving, say, a 45-minute wait in a chaotic lobby for the return trip or an unprofessional driver, that final memory taints their perception of the entire episode of care, regardless of how brilliant the surgeon was.
Exactly. The quality of care is judged not only by the doctor's bedside manner, but by the professionalism and courtesy of the transport driver. We need to detail the specific quality factors that shape this extended perception of care.
Okay, what are they?
First, vehicle accessibility is absolutely non-negotiable. And I don't just mean having a ramp, I mean ensuring it functions smoothly and that the vehicle is comfortable and well-maintained.
And driver professionalism is key. This is a person who is often assisting someone at their most vulnerable.
Absolutely. That driver is the face of the system outside the clinic. They need to be courteous, safe, and empathetic. Clear communication is also vital. The patient needs to know precisely when the ride will arrive and who the driver is. That minimizes that agonizing wait time.
And what else?
And perhaps most importantly, respectful assistance. Getting the patient safely from their front door, assisting them into the vehicle, and ensuring they are secured properly for the journey.
These are seemingly simple factors, but they reinforce the patient's dignity during a very vulnerable time.
They do, and the emotional impact of that cannot be overstated. A positive, reliable transportation experience reduces anxiety and supports a patient's sense of dignity and respect. For someone already facing intense physical or emotional health challenges, a respectful, smooth transport experience is subtly therapeutic.
How so?
It confirms that they are valued, that they are seen as members of the community, and that their journey matters. And that strongly reinforces their motivation to continue with challenging treatment regimens.
This really elevates transportation from being a necessary cost center to being a critical component of patient satisfaction metrics and quality improvement initiatives.
It has to.
It's an investment in holistic care, acknowledging that the patient's life doesn't start or stop at the clinic door.
It is the ultimate expression of value-based holistic care because it explicitly recognizes the environmental and logistical prerequisites for health success.
Okay, let's pull all these threads together now and look at the highest strategic level, the system-level impact. We've discussed the immediate operational costs, the link to SDOH, the patient experience. Now let's synthesize the macro benefits and the argument for mandatory system investment, especially in the modern payment landscape. Can you review the efficiency gains one last time, but with a focus on sustainability?
The fundamental argument for any administrator is this. Dependable healthcare transportation directly supports sustainable, resilient healthcare operations. As we've reviewed, fewer missed appointments mean less wasted provider time and massive reductions in administrative churn. But furthermore, better adherence to treatment schedules means patients get healthier faster, requiring less complex and expensive intervention down the line. Reduced reliance on the emergency room for primary care issues means resources are deployed appropriately.
So all of this contributes to a more stable system.
It contributes to a far more sustainable, financially sound healthcare operation that can handle population demand effectively.
This is so crucial right now because healthcare systems globally are transitioning away from simple transactional models. So connect this logistical reliability specifically to the demands and the financial structures of value-based care, or VBC.
Absolutely. The traditional fee-for-service model, as you know, paid providers simply for activity, for ordering tests, performing procedures, regardless of the ultimate patient outcome.
You did more, you got paid more.
Exactly. VBC flips the script. Now, systems are financially rewarded based on demonstrating high-quality health outcomes, exceptional patient satisfaction, and overall efficiency. And crucially, they're financially penalized for system failures.
Failures like
High rates of 30-day readmissions, poor chronic disease management metrics, and low patient satisfaction scores.
So let me connect the dots. If poor transport leads to a patient missing a crucial post-op checkup,
Okay.
that missed checkup leads to a preventable complication, and that complication leads to a readmission within 30 days. The system loses VBC incentive payments and incurs a hefty financial penalty.
That's it.
The logistical failure has a direct, quantifiable financial consequence.
Precisely. And the impact goes beyond just readmissions. Think about HCA-HPS scores. That's the Hospital Consumer Assessment of Healthcare Providers and Systems.
The big patient satisfaction surveys.
Right. Those surveys include questions about the ease of scheduling, communication, and the overall patient experience. A patient who struggles for 2 hours waiting for a ride home or who misses multiple appointments due to transport is going to report a poor experience regardless of the clinical excellence of their physician.
And low HCA-HPS scores directly impact VBC reimbursement levels.
They do. So in this new outcome-driven environment, transportation reliability is not merely an optional amenity. It becomes an essential, measurable component of successful VBC performance. You cannot achieve positive, repeatable outcomes, the core measure of value, if the patient cannot reliably access the care you are trying to provide.
The investment in transport ceases to be perceived as just an operating expense.
It must be redefined as a strategic investment in generating positive VBC results and mitigating catastrophic financial risks. It is the logistical safety net that prevents high-cost clinical and operational failures down the line.
So if we connect all of this to the bigger picture, and you're advising a major health system or a public health authority right now, what is the single main takeaway for organizations and communities that are genuinely committed to improving health outcomes, improving financial value in the 21st century?
The main takeaway is that you must fundamentally redefine what constitutes the healthcare system. You can no longer externalize transportation, treating it as someone else's problem.
It has to be internalized.
It must be internalized, subsidized, and rigorously managed as an integral part of the continuity of care. Organizations that truly want to improve population health metrics have to recognize that access is foundational, not peripheral.
It's foundational because its influence is so immediate and so widespread. It affects every stakeholder, from the patient's adherence all the way to the hospital's bottom line.
Exactly. Its influence reaches patients, providers, and the financial health of the entire system. Understanding the fundamental role transportation plays in enabling initial access, ensuring treatment continuity, and building that necessary patient confidence, that is the non-clinical challenge that must be solved to improve outcomes at every single level.
From the individual to the whole population.
From reducing individual patient complications all the way up to optimizing large-scale population health metrics. The curb outside the patient's home is as vital to their health as the operating room. So what does this all mean? It means recognizing the integral nature of reliable transport allows organizations to proactively address system gaps long before a patient experiences a health crisis or generates a costly no-show.
You have to get ahead of the problem.
We need to stop waiting for the no-show data to retrospectively prove the failure. We need to proactively provide the solution that removes the barrier entirely. Solving the transportation problem is, in a very real sense, solving a significant portion of the access and continuity problem. It's transforming potential chaos into reliable care delivery.
And if healthcare outcomes are influenced so heavily by a non-medical prerequisite, by what happens logistically outside the hospital walls, it really compels us to ask a larger, more provocative question.
Go on.
We focused on transportation today, but what are the other invisible prerequisites? The mundane logistical details, the quiet environmental factors. What are the other things that we must urgently recognize and address if we are truly going to improve patient care, achieve equitable health outcomes, and ensure that our clinical excellence is matched by logistical excellence in the 21st century? The keys to health success may lie in the places we least expect.